Hi, Vanessa.
Hi, Cara.
Well, we get a lot of questions about plastic surgery
We sure do.
and not about adult plastic surgery. Although I get those questions sometimes too, going to be
I don't
honest.
get those questions.
Shh, not doctor. Um, but we get a lot of questions about plastic surgery in kids. People are confused. They are looking for information. They are trying to weigh self-esteem issues and functionality, like when certain body features interfere with activities of daily living, right? A big breasted young girl who can't run, can't play sports, someone who has a nose that cannot breathe well, right? There's so many iterations of the question that we get. And up until now, we have not discussed plastic surgery because we were waiting to do it with a plastic surgeon. And enter Steve Teitelbaum, who is a plastic surgeon in LA, whom I've known for many, many, many years. One of the things that I love most about Steve's approach is that he is a total data nerd. He throughout the episode points to, literally physically points to the stack of printed articles that he reread last night in advance of the episode so that he could have the numbers at his fingertips.
He was the most prepared guest we have ever had. And by the way, we've had many, many prepared guests, but it was so incredible at how up to date he was on, all sorts of complicated questions. And then the questions we so often get revolve around how old should a kid be for certain procedures? When is it safe? When isn't it safe? How does their growing body affect whether it's the right time or not? How do we handle the self-esteem issues connected to surgery? When is it considered cosmetic and when is it considered health and safety and functionality? And Steve gets into it with real empathy, honesty. And what I love most about this episode and Steve's perspective is he gives the kids so much credit. He really appreciates how insightful and thoughtful and articulate kids are and how important it is that their maturity match the conversation about making a big decision about their bodies.
And it doesn't hurt that he's really well respected in the world of medicine and academia. He's a teacher. He's written a number of papers. He is the president of one of the national research societies and the California State Society within plastic surgery. He's on the editorial board of a plastic surgery journal, a big one. And he's an associate clinical professor of plastic surgery at UCLA. So Steve has real cred, and he also has real cred. We hope you'll enjoy. Let's just jump into this massive topic of plastic surgery in tweens and teens. And I think the best place to start is by explaining a little bit of the terminology so that we're all on the same plane. So, Steve, what is the difference between reconstructive surgery and plastic surgery?
So I would say it's all plastic. The distinction I usually would make would be between reconstructive and then either cosmetic or aesthetic. So take cosmetic and aesthetic as synonymous versus reconstructive. So in a broad sense, reconstructive is the creation of the normal, and cosmetic or aesthetic is taking something that's already normal and enhancing it.
And when we use the word, and I know as a physician, the word normal is a loaded term. When you use the word normal, Steve, talk us through what, from a medical perspective, what that means from your
That's
sense.
a great question, is how I would define normal, because everybody has slightly different interpretations of it. Insurance companies will often define the normal as being anything that's not functional and only define abnormal as functional. It's like the discussion of eroticism versus pornography is I know it when I see it, but there's some hard lines in the sand. So to get very specific, For instance, breasts are expected to develop relatively symmetrically. And it's normal for breasts to be small. It's normal for breasts to be large. There's nothing abnormal about relatively symmetric small breasts. And there's nothing abnormal about breasts that are a little bit different. But when it gets to the point that the difference in the two breasts is very visible in clothing, then you can start to say that there's something a little abnormal. There's no upper limit on how large a breast is that's normal. There's nothing abnormal about triple D breasts. But if it's causing discomfort for that woman and is giving her symptoms, then you would say that that's something abnormal. Does that sort of guide?
So in some ways, it's sort of appearance from the outside, right? From someone looking at another person or a person looking themselves in the mirror. And in some ways, it's about function or kind of life functioning. I don't know what the term is, but it's not all one or the other. And as we often talk about, Steve, like asymmetry in the body, whether it's labia or testicles or breasts, that to some extent it's expected. But as I'm sure you've experienced in your practice, there are people whose asymmetry, for instance, in the breasts, it's very dramatic and it's causing, it's on another plane than what we might consider to be typical.
But interestingly, you threw in insurance,
right?
Which is a very important piece of this conversation because they are the payer often, not always, but often. So there's what the person is experiencing, where the doctor is placing this along a spectrum of expected to unexpected. And then there's this third party, the insurance company, that may or may not pay for it. They've got their own determinants that will layer into this decision. And that's confusing across medicine for 150 reasons. But Steve, I would imagine in your work, you have a lot of that to wade through.
Well, I do and I don't. The first part of the answer is I'm not a provider on any insurance plan, so I don't have current knowledge of what each company is doing. But what I can say, having recently reviewed a lot of articles about teen and adolescent and young adult plastic surgery, is that payers are increasingly paying a smaller and smaller amount of these things, that they're being very strict at distinguishing of whether something is functional or not. The insurers are so horrible that children who've had a cleft lip, they frequently need revisions of their nose just to make the nose normal. There's an example of a reconstructive nose job, but every person, if you saw one of these children as a teenager when they need their nose adjusted, would agree that it's reconstructive. But the insurer's saying more and more, oh, that's just that's not functional, that's purely cosmetic. Now in California, we have a law that requires them to pay, but they still try to shirk it. So the point to understand is that the insurers are less and less frequently paying. The one procedure they tend to pay for is a breast reduction. If you can document significant symptoms, neck, back, shoulder pain, rashes under the breast, grooving from the bra strap, they do pay for that. For breast asymmetries, developmental abnormalities where the breasts don't match at all, under some state laws, they are required in theory to pay for it. There was an act passed that required insurers to pay for treatment of the non-cancer breasts in older women who had a mastectomy for cancer, recognizing that the goal is to create symmetry. And if you only treated the cancer breast and don't do an adjustment on the non-cancer breast, you can never make them equal. So that has been interpreted in many states to apply to teenagers. However, the insurers still successfully manage to shirk that responsibility in most situations.
We're going to get in a minute, Steve, we're going to go down the path of a variety of kind of specific topics, but I want to cover a big question, which is, what are the surgical risks for kids? And we can figure out how we define kids in this conversation relative to adults. And are we talking about kids with respect to their age, their stage of puberty, their how do we determine when a body is an adult body?
It's a great question.
Context?
And I'll break the question into two separate areas. One is the risk of the anesthetic and the risk of the procedure, and then whether the patient's age, they are yet anatomically ready to have it. There have been a lot of articles. I have a huge stack here I just read through. And what's reassuring is looking at the safety of procedures in teenagers that are also done in adults. They actually have a lower complication rate. The rate of anesthetic reactions, the rate of infection or bleeding or other kind of problems we are concerned about actually are lower in them. So the most reassuring thing, and never to be cavalier about it, but the data is very clear that these procedures are at least safe from a health point of view. Of course, assuming good surgery, good anesthesia, patients being worked up by their pediatrician. But excluding that, they can be done safely.
Which makes sense. I want to put a pin there for 1 second and say, this is not a tremendous surprise. I mean, when you think of a surgery like getting your tonsils and adenoids out, it's a great example of it's not cosmetic, right? A plastic surgeon doesn't do this surgery. But what we know is that the older a person is when they get this surgical procedure, the higher the complication rate, not for any reason other than it's the way their body responds during surgery and postoperatively. So that data is very interesting and to me, not tremendously surprising.
And then I'm not sure how much this fits into your topic, but the only pre-teen plastic surgery done routinely on children, other than those that had a birth defect like a cleft lip, would be prominent ears, which you typically do, as you would know, 5, 6 years old, usually before first grade. By then, the ears have reached their full size. You want to hit it before they start to get teased. And the ear is most malleable at that age. And we know from a very large experience that it's safe to do that procedure on those children at that age. Most of the other procedures then that we're talking about skip to a little bit more into adolescence when you start talking about the nose, the breast, and the chest. So then getting back to your question is, what are the ages for that? When you don't want to, there are two things. You don't want to operate on something that's still in a state of flux. You kind of want to know what you're dealing with. So in other words, you want breast growth to be stabilized, nasal growth to be stabilized. And it's also important because when you operate on a structure, the classic example is when you do a nasal surgery. When you operate on those bones, you actually impair future growth from just the work that you did as a surgeon. So you want the bones to be grown so that you're not relying upon future growth because you could kind of stunt it. So, they usually say like 15 to 17 is around when it's appropriate for women to have nasal surgery. In boys, a little older, 17 to 19, because their facial growth ends a little bit later.
Steve, do people do, how in pediatrics we do hand films, x-rays of the hand to look at how far along a child is in their growth trajectory? Can you use images like that to then predict where they are for, say, a rhinoplasty, a nose job, or something like that?
It was funny you said that. I was thinking about that yesterday. I looked through all these articles. I didn't see any mention of it, and there could be something that I missed. I think the assessments that are being used are menarche, stabilized weight, not seeing ongoing changes. The child or young adults, I'm not even sure what word we're using now, child, young adult, teen, their ability to articulate what's bothering them and rationally explain from themselves why it's something that they want to deal with. Those are the focuses rather than looking for something as hard as an objective as you're talking about, Cara, with like the hand x-rays.
Okay. At what age can someone get plastic surgery without parental consent?
I don't think anybody can get anything if they're under 18, right? You need parents' consent for anything under 18.
Okay. So, and I just want to level set for everyone. So 18 or older is when kids can consent to their own medical procedures, right? What about the reverse? What about if a parent of a minor is pushing for a surgery, but the kid doesn't want it?
I have not personally encountered that. I think that's an interesting thought experiment. And I think that it's like trying to convince your children to get braces or to do their homework. I think it's an individual thing between the pediatrician, the parent, and the child to try to convince the child what the parents and doctor think is best.
So, Steve, you talked about breast growth being stable. But as anyone who owns a pair of breasts will tell you, they are never stable. And I mean that in every sense of the word. Throughout the course of a month, throughout year to year, from stage of life to stage of life, breasts change constantly. Weight gain, weight loss, there's a million, your menstrual cycle, everything. You've got a kid who is just miserable. You've got a kid whose back is killing, the bras are uncomfortable. Maybe she can't participate in the sports she wants to play in. Maybe she's like restricting social activities because of discomfort or self-consciousness, right? Like the breasts are really, really getting in the way of normal life functioning. And yet, maybe the kid isn't deemed, old enough, or maybe the breasts are still developing and changing. How do we determine, is it worth doing it for respite for a given stage of, a period of years, knowing maybe the breasts will grow back, or they're still going to grow in height and weight and all of those things. Like, how do we balance these questions?
So your question is about a young woman considering a breast reduction.
Yep.
Who you're wondering if she may lose weight and the breasts may better balance her body, but yet she's already having symptoms. Is that right?
Or she may gain weight, and so the breast reduction maybe is less effective because, the weight gain puts weight back in the breasts.
Okay, so you asked the best and most difficult question because you've thrown in all of the confounding variables into one question. So
welcome to Vanessa.
As you know and have written about, childhood obesity brings upon earlier menarche. It also creates a greater degree of breast growth. Disproportionate breasts cause anxiety and body image issues and psychosocial things, which can further contribute to eating and difficulties like that. Most surgeons agree, and the studies, like I said, I just read through a lot, very clearly show that if a woman is having symptoms of discomfort, psychosocial issues, self-esteem, difficulty dressing, playing sports, that you achieve a tremendous benefit by doing a breast reduction. A breast reduction is an operation in a teenager that is consistently shown to create the highest satisfaction in self-esteem and improvement in lifestyle. It's the perfect operation. It improves discomfort, right? The alleviation of pain is our doctor's number one task. And we do that with this.
Okay. So I want to go a little deeper into this question because I know a lot of the data. I've read a lot of the studies you've read, and yet I'm weighed down by all of these personal stories and experiences that I've heard over time. So I want you to help us through some of them.
Okay.
So can you get a breast reduction too soon? I had a number of friends in college. Now, this was in the late 80s, where I think the technique was probably very different, but they had breast reductions between high school and college for all of these very valid reasons. It was a successful surgery. They were thrilled to have had the surgery. And yet, a number of them then had breast regrowth, some during college and some not for, a decade or so, but then when they got pregnant or had babies and were nursing, they had breast regrowth. So can we talk about that a little? Have the techniques changed? How big a risk is that?
Okay, so the first thing is I wouldn't consider breast regrowth years forward with lactation or with menopause an argument against doing it in the teen.
Okay.
But the patients the friends of yours you described who just in the next 2-3 years following it had an issue, that to me would be what I would want to focus on.
Right.
The studies look at breast regrowth, and there's several important things. The rate of request for revision for saying that I got too big again afterwards is extremely low. It's in the high single digits. So it's very few actually request. Most of those are also people who had gained weight afterwards, whereas most people lose weight afterwards. Even among the people who request to be smaller, you've still made them a lot happier by virtue of doing it. In other words, the study showed that those patients still achieved a successful outcome, even if they should wish. Now, I don't know, honestly, the techniques are better, but those are probably very specific to there's always a conversation with each patient. How big are you? How big do you want to be? How small do you want to be? What do you want to look like? And there's a lot that goes into planning of the surgery. You could do a whole episode on how a plastic surgeon tries to learn from a patient what result she wants as opposed to what she wants for her reduction.
Okay, but this is the next piece of it, which is we all know. I mean, Vanessa and I spend all day, every day talking about how the decision tree of the teen brain is very unique and their limbic system is on fire and they're making choices that they would not make 5 or 10 years later. So how do you have that conversation with what you want with a 17, 18, 19-year-old who may actually want something today, right now, that 5 years from now, they don't want?
And can I just add 2 specific questions to that? One is the ability to breastfeed, and whether breast reductions interfere with that ability down the road, which is something a teenager might not be thinking about, but a parent.
I want to touch on, okay, I'm going to take Vanessa's question first because that's so important. What's interesting is that women who've had breast reductions are able to breastfeed at very high rates, but they attempt at lower rates. I think there's this notion that they're not going to be able to, so they don't even try.
I think it's like an urban myth certainly as when I was a young woman and if people were getting pregnant,
That's
it was
right.
The understanding that if you'd had a breast reduction, and I know many women who have, they wouldn't be able to it was just accepted as a fact.
That's because I think, Steve, tell me if I'm right, there were duct sparing ways of doing a reduction and there were non-duct sparing.
Correct.
Okay.
So every reduction since we've all been alive has not transected the ducts. The breast gland remains in continuity with the nipple. Here are the issues. The first issue is that oftentimes women with larger breasts have flatter nipples to start out with. Not always, of course, but they tend not to protrude as much. They may have less sensation. That sensation may be reduced a little bit. So they always have to distinguish milk production from sort of the ability for the baby to suckle.
Reduced from the surgery or reduced from other factors? Both.
That stretch of the nerves we imagine. There's this urban legend. I don't even know if it's true that women with smaller, very small, champagne glass type breasts will have more sensation in their nipples than women with large breasts, with certain exceptions, right? So, and then surgery by cutting things can only exacerbate. Right. You're not going to increase sensation with surgery. But studies that look at it, people who attempt to breastfeed after reduction, more or less 70% are able, but you don't know that, but 100% of women are not able. And it varies. People say, my first baby was so hungry, I supplemented. Well, does that mean she couldn't do it? Second baby had trouble latching on. Maybe you got a lactation coach. Maybe you stuck with it. Maybe you didn't. The only message I would put out there is reduction patients are probably able to breastfeed. Don't be afraid to try, but understand if that's the most important thing in the world to you, and it should be important, know that all the paperwork will tell you that there is some chance that it could impair your ability and make your own decision. Tara, your question about the maturity of teens at making these difficult decisions and articulating what they want. Not disputing the truth of that, because I have children and I remember the way I thought at that age. I'm consistently impressed with how well women who have large breasts articulate why they want to have surgery. This is not a population of women who come in with odd concepts, disproportionately blaming their breasts for things or bringing in photos of supermodels. These are people who very could, like, I love soccer, I have trouble running around. I can't find a bathing suit to play with my friends. I'm always hunched over. And the mother will say, look, she's a shy girl, and men are constantly leering at her, and she's a beautiful woman. And the children, a young adult, they articulate it so clearly that I have not found that to be an issue. Now, this goes slightly tangential, but let's say, In the last few years, a couple times a year, I'll have a typical breast reduction patient based on their symptoms and what you see in front of you, where they'll say something like, I'm gender fluid, or I'm gender ambiguous, or sometimes I'm more male, so make me smaller than you would. Okay, and there you start to walk maybe down a different thing you have to consider. But so far, all of those patients are at least very articulate and thoughtful when I've had those conversations.
And I'll add to it from our perspective, the kids we hear from who are curious about breast reductions, so many of them are also open to the idea that they are growing, their bodies are changing day to day, and that if they sit with it for just a little bit longer and see where things settle out, they might come to a better conclusion for themselves. I cannot count the number of kids who at 16 were certain that they would end up getting a breast reduction before leaving the house, going to college, whatnot. And by 18, actually changed their perspective of their body and came to say, well, you know what? I'm glad I didn't do anything at 16. I actually want to sit tight for a little bit longer because I'm not sure. And I agree with you. There's this thoughtfulness to it that I think the urban mythology of all of this loves to paint a picture of kids just being on TikTok, seeing what they like,
Right.
walking into an office, showing a picture to a plastic surgeon, and that plastic surgeon saying, sure, I'll do that, right? So every step of the way is not accurate. Can we flip it to breast augmentation in teenagers and talk a little bit about—
Can I just say one more thing about breast reduction to you as a pediatrician? Pediatricians have a lot of reasons for prescribing birth control pills for teen women, even if it's not specifically for contraception. And there has been concern that that will increase breast growth. But in fact, it shows that it limits some of the breast growth. And it's an active area of interest. And there's not a lot yet written about it, but that's something to bear in mind.
And on that, there are certain kids who will take certain hormone doses and combinations, and they will have tremendous breast swelling, and others do not. And so the impact is very individual. But for the kids who do have breast swelling and tenderness and all that with the oral hormone they're taking or the patch or the shot, talk to your doctor.
Steve, when you say limiting, do you mean that it is certain hormonal combinations will reduce breast size or cap breast size? And when you say it's of interest, are people considering it as a sort of like preliminary or pre-surgical option, given the research about hormonal contraception in that way?
So the article is very limited. It started by saying that oftentimes parents and pediatricians who otherwise would want to give a specific young woman birth control pills do not for concern of increasing breast size in someone where it is already large. And what they said is that though the pill causes some edema, some swelling,
right,
it actually reduces the amount of proliferation of actual glandular breast tissue, and that it may actually help reduce the true extent of breast growth. But lest I be misunderstood, this is an area where I'm just trying to dispel that myth, but I'm not yet saying that birth control pills are something that you should use to reduce breast growth. I'm not saying, I'm just saying it's an interesting thing, that something that you guys, would think about. It is also one of those things, like, as doctors, like, this paper really was aimed more at pediatricians, but was in the plastic surgery literature. And there probably are things in pediatric journals that I haven't read that I should be reading. You would think today that there would be a better cross-pollination of our literature than there really is.
That people wouldn't be siloed into echo chambers? Steve.
Exactly.
Steve, I interrupted you. Do you remember what you were going to say before I interrupted you?
No, let's move on. I think you guys want to talk about augmentation.
Well, we want to talk about augmentation, then we want to go to other body parts. So will you walk us through conversations that are had with teenagers about augmentation? Because I would imagine that's totally different, right? Than reduction.
Let me be clear about augmentations. Okay, right. The true augmentation that you think about, hi, I'm an A cup, I want to be a C cup. I'm a B cup, I want to be a C cup or a D cup. I want my breast to be bigger. That is almost non-existent in the under 18. We're talking nationwide at some 4-digit number, whether it's 1,000 or 2,000, it's way less than 0.5% of all breast augmentations.
What's the total number of breast augmentations? What's the total number of breast augmentations?
200,000.
200,000 a year.
Like 300,000.
Okay.
It's a very small number. In my whole career, I've only seen a couple people come in for that, and I've never done it. Speaking to colleagues in preparation for this, it's a similar thing. Like, yeah, I don't see them. They must be out there, but I don't, look, there could be some subgroup of plastic surgeons who, for certain socioeconomic reasons, they have the mom who's into really big implants, and the mom sees it with the kid and brings the kid, but like, you don't see it. I don't see it.
And you're based in LA. Like, you're not in Omaha. You're in LA. So if
all respect to Omaha. Right.
But with all respect to Omaha, but like, if someone was going to see it, it would be likely you and your colleagues would be likely.
I wonder that, because breast size, the desire for breast size is usually socioeconomically related. And that, west side of Los Angeles, yoga, soccer, Tracy Anderson moms are getting smaller breasts than Inland Empire moms, by and large. And some of those moms may see big breasts as a rite of passage and something to do for their daughter before going to college. Like, I'm even being silly because I'm speculating. I don't see it. Everyone wants to talk about it. If you look at beauty magazines, there's always the story on the cheerleader who got the implants for the squad and the graduation present liposuction. I know everybody wants to talk about it. I'd love to talk about it. I can't speak from experience because I don't see that as a real phenomenon. What I see when it comes to breast augmentation is the treatment of significant asymmetry in which one breast needs to be enlarged, or non-development of the breast. And I consider those reasonable and medically indicated, different than the traditional augmentation.
How about other body part augmentation? And now we're bringing males into the conversation. I mean, there's, you read the same magazines have lots of articles about calf implants and butt implants and all these things. And we've got this essentially an epidemic of bigorexia among males. They want to bulk up. They are using all sorts of tactics, whether they're workout tactics, supplements. Do guys walk into your office as teenagers and ask for implants?
Never. But then I don't do those implants, right? So in other words, if they do their research or they call my office, my staff will tell you that I don't do it, so that I don't see it. But I think that a couple of things. You have to first remember that anybody under 18 probably isn't making the money to pay for it. So you've got to imagine what kind of parent, what 17-year-old boy is going to talk his parents into paying for calf implants. I don't think it happens. I think
that is a very persuasive.
Just work out more, and that's what you need to do. But gynecomastia.
Yeah, I want to talk about that, Steve.
Okay.
So listeners who've been listening for a long time know that about 50% of guys have some breast development, breast budding, or more during puberty, and that often it resolves, but not always. The clinical term is gynecomastia, which sounds like a dinosaur that you hadn't heard of. But if you break it down for us, Steve, the origin of the root of the word is?
Well, gyno, isn't that feminine, and mastia is breast. And it's really distressing for exactly the etymology as you brought up, is that, boys are so concerned about maleness and young girls about womanliness. I know women are excited when they see their breasts to some extent, right? And boys are excited when they see the changes in their bodies. And I remember myself having and sort of wondering, like, did God not sure what I'm supposed to be? And it sort of looks a little girl-like. And, the difficulty with gynecomastia, as opposed to breast reduction, right? Breast reduction, once they develop, unless there's a tremendous weight loss, they don't really go down. With gynecomastia, a lot of times they do go down. So it's a question of ascertaining how significant it is, how correctable it is, and how much it's bothering the child.
And let's talk about the why for a second, of why it resolves. I just think it's really important to level set that estrogen is the primary hormone that's turning on and maintaining breast growth and development. And everyone has all the sex hormones, but males, as their testosterone levels continue to rise through their tweens and teens and 20-somethings, think of testosterone and estrogen like sitting on a seesaw. The more testosterone there is relative to estrogen, the less estrogen effect you'll see. So the estrogen that's floating around in the body might tell male breast tissue, because everyone's got breast tissue, to start developing. But then when it's flooded by testosterone and that estrogen essentially is washed out because numerically it just doesn't have a seat at the table, that's when we see male gynecomastia resolve. Is that a fair description?
That's a fair description. And one thing to add, which you can explain better than I can, is that gynecomastia is worse in obese boys because they have the aromatization of the. Do you maybe want to explain that?
Yeah. So there's something called peripheral fat conversion. And peripheral fat conversion means that some hormones, particularly the sex hormones, are aromatized. They are shifted using a certain enzyme that lives in fat from one form to another. And we always talk about how estrogen and testosterone are essentially cousins. Well, when you have extra fat tissue, the testosterone-like hormones, and this can include DHEA and DHEAS that come from the adrenal glands, those hormones can get converted into estrogen in the peripheral fat. So your absolute amount of estrogen in your body goes up when you have more fat tissue. It's just like a really nice conversion factory. So that then can signal to the breast tissue to grow.
And Steve, with boys often, I mean, it's so funny because teenage boys can say things in a way that is just amazingly honest and hilarious. And they talk about their nipples. And they talk about, oh, this shirt is nipply, I can't wear this one. Oh, this shirt's good because it won't show my nipples. Like they're just, so you actually would often not, I didn't speak that way as a young woman, but teenage boys these days will get right into it. What do you see when gynecomastia resolves? Are there areas that typically resolve more than others? Are there parts of the breast development that you have seen requires more intervention and others that seem to require less? Like, how does it?
That's a great question. That's a great question. And if we had that crystal ball, then we would. The difficulty is 14, 15, 16, 17-year-old comes in describing what you've described. If we could say, okay, you will get 80% better, 100%, then we'd know who we're operating on or not. And it's hard. It appears that the lean boy, where there's just that puffy nipple, everything else is okay. It doesn't look like a breast. It's just a puffy nipple. Those seem to resolve. The really large ones, where they're really big, tend not to resolve fully, but they're also causing so much of an issue, you're likely to operate on them. And then in the very obese boys, whether they stay obese and go through puberty and it resolves a bit, or they actually lose weight, I find that something always remains in them. They never end up getting flat. In other words, the only ones who truly resolve are that puffy areola. But even that puffy areola, for some boys, it may take just one person teasing them,
right?
One day wearing the wrong synthetic shirt that gets a little sweaty and they notice it in a picture. And the studies very clearly show that the regret rate for gynecomastia surgery is extremely low. The scar is well tolerated. The procedure is well tolerated.
Steve, what's the deal with nipple shaping while you're talking about
nipple shaping?
Yeah.
I've never had. Are you talking about making the nipple smaller or the areola?
Well, we've been hearing about a trend among kids where they actually have a desired nipple and or areola shape. So areola being the flat, darker area on the breast around the nipple. So in some bodies it's red, in some bodies it's brown, in some bodies it can almost look black. And then the nipple being the part that has the erectile tissue that can lift up, right? So we've been hearing about a trend where kids actually are seeking certain nipple shapes. And,
So
I'd never heard of it
I
before.
have to say, I haven't seen it in the office. I'm aware that people have talked about it, but I think it's just I have no experience with it. So I see a lot of patients this age. So one thing I want to mention before we run out of time is sort of how to find the right plastic surgeon. Because one thing that we've concluded with almost all these procedures is they're not hard lines in the sand. Like if unfortunately we were talking about some kind of a cancer, the discussion may be if you have such and such, you have to cut this much off and you have to do this, and that's the way you do it. But there's the opposite discussion. So much about the extent of the problem, how much it's bothering the child, age of the child, maturity of the child, finances. It's such a complicated thing that I think that if a child mentions something, I think it's really important for the parents to listen. It's so easy to say, oh, you're so beautiful, and to dismiss it right away. I think you really have to listen to them. And some kids are going to be able to voice it, and other kids are not. And that's why having a great pediatrician like you, Car, who can suss stuff out, who can hear the things that the kid isn't saying, is so important. And so there always has to be this relationship between the pediatrician, the kid, and the parent, don't you think?
Well, not only do I agree with that, but I think it can be really hard to find a surgeon who's like you, who will sit down and take time and have their own internal screen of, because I would imagine there are plenty of experiences that you can recall, and you don't have to share them, but I'm sure they're flooding your brain, where you had a kid sitting in a room and they said a thing or two, and there were flags going up for you, and there were and you're thinking, I'm going to continue this conversation with this kid, but I'm not going to do the surgery for this list of reasons. This kid is not.
Can I tell you a great story that I always have at lecture? 19-year-old woman came in with her mother for breast augmentation. So she's old enough to do it. I mean, the mother didn't have to be there, just go in. And I didn't yet open up the chart where you fill out, allergies and medicines. 15 seconds into it, she was too immature. The way she was talking, so flip about it, not sure what she wanted or about risk, that without opening it, I said, I don't think that you're ready. I'm not going to charge you for the visit. Okay, she leaves. So I was very polite. She left. The mother seemed to be a little happy. I opened up the chart, and under medications, it says birth control pills and Flintstone chewable vitamins. And
wow.
I just love that,
You're like, oh, my internal meter was right.
But that's the symbolism of this age, Steve, right? You can have those kids, and you can have the kids who can articulate their inner life and their social experience.
Most of the kids today are so articulate. I just think that they get the bum rap, that
it's.
Well, I don't want to finish this episode without talking about noses. Okay. So can we use this framing that you're talking about, and Cara, you're talking about finding the provider and sort of a provider's gut check to talk about rhinoplasty? Cara, I don't know. We cannot finish this episode without
we
talking
have to
about
do
it.
I want to frame it in this way, because I'm chewing on a question I have that's lurking in the background of all of this, and we can apply this to noses. I think this is as good as anything, which is, with most things cosmetic, we can suggest a temporary solution to try something out before you do the permanent solution. Oh, you don't like your hairy legs? Try shaving before you do laser hair removal, right? So there are all these baby steps. In your field, Steve, I don't see a lot of baby steps. So I think rhinoplasty is the perfect example of this framing, which is, a child, a tween teen there. So let's acknowledge the nose grows before the rest of the face. So this is very, very important for parents of middle schoolers, especially. There's this thing that happens where the mid-face grows quite quickly, and the jaw and the forehead have not caught up. So maybe we can talk a little bit about that. And then let's get past that stage to their face has sort of settled into their adult proportion, and they don't like their nose. It makes them feel bad.
Or more than that, Cara, they are miserable.
They're
are
miserable.
miserable. And they will say, I hate how I look. I can't stand looking at myself in the mirror. I don't want to go out. I don't want to like, there's not liking. And then there's like,
and there's no middle ground, try this out solution, right? There's no like shaving your legs before electrolysis. So can you walk us through what that's like from your side of the exam table?
It tends to be less difficult in reality than you're describing. In other words, you can say someone's unsure of whether they'd look better or feel more comfortable with hairy legs or shaved legs. But people are very articulate that when I smile, my nose plunges down. I don't like my side view because I've got this big bump like a witch. Young girls and boys who talk about their nose are usually extremely clear and extremely specific. And in the cases where they're not, then a thoughtful surgeon will recognize that. In other words, these visits, they're less ambiguous than you want to think they are. They're usually very clear and rational.
Sometimes, Steve, I think that parents who are raising kids through the mental health crisis think that these surgical solutions are complete solutions. How do you navigate that? You have a kid who's legitimately unhappy with how they look. They're articulate about it. There is a solution for it, but you also know there's something more going on underneath. I know the role of the pediatrician there, but what about the role of the plastic surgeon? Is it important to help families scaffold some mental health support for kids who are feeling no self-esteem or extraordinarily low about themselves?
There's always this question of, is the reduction in self-esteem attributable reasonably entirely to the nose or any other part? And if you correct that part, how much of that self-esteem do you correct? What's interesting in these studies that I've been looking at is even subtle things can cause a very significant difference. In other words, it's not linear. It's not like the person, you go bigger bump, bigger bump, bigger bump on the nose, the self-esteem declines in a linear way. Obviously, every plastic surgeon will tell you that we are not psychiatrists or psychologists, and we don't operate on your underlying emotion. But yet at the same time, we show studies with objective indices of self-esteem and quality of life that show improvement after what we do. But the parent and the pediatrician and the plastic surgeon all have to be aware that for every child who has, even with the worst deformity, there are other things in their life that are affecting their self-esteem every day. And that you can't ever look to the surgery as the sole solution to all that's problematic.
Steve, how do you know, or how do you determine when the nose growth is? I mean, Cara asked about the growth plate test. Do you guys use that? Like, how do you decide? I mean, I feel like my kids wake up every morning and like, I swear to God, they look different to me, every morning. And I've got everywhere from 13 to 21. So
one of the first questions, I mean, you wonder how old they are, right? So as I said, girls 15, 16 to about 18, boys a couple years later. But usually the mother or the father, they're very clear. It's like, this is her nose. This is the way she looks. It kind of comes down to something simple like that.
Okay.
Now, I can imagine outlier situations where there's something so horrendous, for lack of a better word, in a younger person that you have to make a determination. Do we do this earlier than we ideally would? Because this is so horrible. But now it's almost a reconstructive thing, because now you're talking about creating a normal out of something that's not yet normal.
Can you talk about, because this is something I've dealt with, and I'm sure many people have, a broken nose from an athletic run-in. My son's run-in was with an elbow on the basketball court. But like, how do people know whether they need to see a plastic surgeon, whether it's worth doing? Because you talk about that it stops growth.
Broken nose is you operate if it is deformed. In other words, if the bone breaks and it's not displaced, meaning that didn't change the shape, it does not need to be operated on. Now, there is a window of time, usually in the 5 to 10 day period, where the swelling is down enough that the family can assess if the nose looks normally, but yet the bone hasn't started to mend yet. And so that's when you want to do it. But I get calls all the time running to the ER for an emergency CAT scan. It's like, ice it, take your time, make sure the kid is breathing. and talk
that's
to your
really
pediatrician.
helpful.
It's a common thing. Talk to your pediatrician, get a lead on a plastic surgeon who's going to be good for this. There's a very specific thing doing broken noses in children. So your pediatrician in your community will know who is seeing these kids because it's a common thing, and they'll tell you who to see.
I think this is a perfect place to land because I'm flashing back, Steve, to an evening when my daughter was about 10 years old, and she too had a run-in with an elbow, and she had an instantaneous asymmetric nose deformity. One side of her nose just swelled up like a balloon. And I called Steve and I said, I don't know if I need to be worried. And I've seen a lot of noses in my time. And I drove over to Steve's house. And she sat on Steve's kitchen island and he examined her and he said, nope, not broken. And, we iced like crazy and the deformity resolved over time. It is really hard for a non-surgeon to tell, but you start by reaching out to your pediatrician. And if your pediatrician is the one with the problem, then they call Steve. The last little bit that I'll tack on is, speaking of ERs, you also want to reach out to your pediatrician or ask the emergency room physician if a plastic surgeon really needs to be involved with the sewing of those stitches. So there's we get this call all the time, do I need a plastic surgeon to sew so the scar is minimal? And the general rule of thumb for almost everyone, those who sew and those who don't, is if it's on the face in a place that is very obvious, or if someone keloids, so if they scar as they heal, you really want to have someone who's trained to sew to minimize the scar. And it's always fair to ask whatever doctor is seeing you, and pick up the phone and call your pediatrician if you're worried.
Steve, you clearly have to come back because I have 8,000 more questions. And you know what? I think you win the award for most preparation ahead of an episode. Like, you have done your homework, certainly more than my children have this week. And it is such a pleasure. And it is so affirming because we strive to give people research-based information, peppered with anecdotal and experiential backing. But I so appreciate how much you reviewed the literature and given us a real sense of what's out there. So thank you for your honesty, for your care of these kids and thinking about them as whole human beings. I think that's so important. And for doing your homework so well.
Thank you, Vanessa. Thank you, Cara.
Bye, Steve.
Bye,
Bye-bye.
Steve. Thank you so much for listening. You can email us with questions, feedback, or episode requests at podcast@lessawkward.com.
If you want to learn more about what we do to make this whole stage of life less awkward for everyone involved, our parent membership, our school health ed curriculum, our keynote talks, and more are all at lessawkward.com.
And if you want products that make puberty so much more comfortable, visit myumla.com.